All right. Well, I'm going to ask you guys to introduce yourselves. Tell me a little bit about your background, and yeah, go ahead. You go first.
Me first?
Yeah.
Absolutely. Avio Elizondo. I'm a dentist in South Texas, Harlingen, Texas, and went to dental school in San Antonio, the UT Health Science Center. Graduated in 1998, and graduated undergraduate from Texas A&M University in 1993. And I've been practicing down in the Rio Grande Valley now for the last 28 years, and really enjoy my profession. I enjoy it.
How'd you get into ortho?
I found out through a friend of mine about some orthodontic training that was being done by Dr. Williams with the AOS. And I went to register for the class, and I was told that it was only in Orlando that week, already starting that week on a Monday. And I didn't want to wait because I was motivated to start orthodontics. And I didn't want to wait, so I registered to fly to Orlando, and I met Dr. Williams, and it changed the rest of my life. Really, it did. I had sunk into a kind of like a low professionally, and I didn't realize that this was something that I needed, And so I always give credit to Dr. Williams because he did have a big impact in turning my professional career around. And so I've always tried to stick around wherever he's at, just because I feel a lot of motivation from being around him and listening to him. And so that's how I got into orthodontics, and I've been doing that since 2018.
I paid him to say that. I'm Brad Williams, and I practiced dentistry in Skytook, Oklahoma for 43 years. And I'm still in practice. I've had my brother's a dentist. He worked with me some and was in and out of the practice a couple of times. And my two sons are dentists as well, and they both have worked with me and have been in the practice and have left the practice, which I don't know what that says about me, because it's got to look like I'm really, really hard to work with. I don't play well with others or something, but now they've all moved on in their careers and to I guess what they consider greener pastures. But Skytook is my hometown. It's where I grew up. It's where my dad grew up. My grandfather was a teacher there, and so it was. I don't know exactly how I got interested in dentistry because it happened so long ago. I was 11, fifth grade, and I have 9 fillings in my teeth, and 8 of them were done when I was 11, and I still have those same fillings.
That's pretty incredible.
They're 57 years old. And so that may have been some of it. I mean, it wasn't a wonderful experience or anything, but I did think it was pretty cool. I also got orthodontics started, braces back. This is pre-1970, so this is edgewise orthodontics. So there was no such thing as bonded brackets then. So I was full bands and edgewise. And I also had an RPE expander done during that time. But and it was around that time that one day I sat down and started writing down the things that I thought I was good at and things I wanted out of a job, and dentistry was the matchup, and then I never ever changed my mind after that. And part of that whole dream was to go back to Skytook and practice, and that's what I did.
We have some expertise here on the podcast, and I wanted to get some sort of feedback from you guys. A lot of stuff has changed in orthodontics over the last 20 years, 30 years. And one of those things that has changed is it's become much more popular for dental practices to offer some type of orthodontics, whether it's clear aligners or other things. And with that, there's a lot of questions or confusion about what the standard of care records are for those types of things and what the risks are for the practice when taking on orthodontic treatment. First of all, maybe you have seen some of this shift over time. What have you kind of observed from your perspective?
Yeah, I'm actually working on an article right now for the journal, if our editor is willing to publish it. But and it is addressing cephalometrics specifically as an important part of the records that we take in orthodontics. I don't know. It's my take on the history of it is that back when I had braces and it was edgewise, the technique was really so difficult and so skill oriented that only orthodontists would want to do it. And when Andrews came along and we went to straight wire, it really changed the dynamic. And so I think that a lot of dentists then became interested in getting involved because it was more doable. There was less wire bending, and it was then brackets that got, there were bondable brackets, and it just the whole technique got simpler. And but it still came down to good diagnosis, and you can only get a good diagnosis and generate a good treatment plan if you've got the database. You got to have radiographs and analysis and in order to make decisions about the case. And so I think that was back whenever everybody first got interested. The one thing that a general dentist that was getting involved in straight wire, which still made you feel like that you were crossing over into somebody else's turf, that you were behind enemy lines. And so the last thing in the world you'd want would be to have less than the standard of care records or anything else that made you vulnerable to criticism or some kind of civil or legal or board-related problem. You're really going to try hard to cross all your T's, dot all your I's, and do it all right. So then another decade or two goes by, and there's pretty much a solid percentage of general dentists that were doing straight wire. It's probably still under 10%, but there was this solid number of guys who were willing to put those records together and do that. But then another decade goes by, and the aligner game came on the scene, and it was initially Invisalign, and at that point, of course, it was being driven by the companies that want to sell aligners. And so I think that those guys were all trying to break down every barrier that would stand between you and you getting into the game and doing aligners. So they started talking about, we'll generate the trays. We've got this wonderful program that'll generate the case. You don't have to worry about the tooth movements. You don't have to worry about a bunch of diagnosis and treatment. You send us the case, and basically we'll tell you whether it's appropriate or not, and we'll map it out. All you really have to do is just monitor and hand out the trays. And it worked. I mean, the orthodontists rejected it initially, and then the general dentists picked it up and they ran with it. And whenever the orthodontic community, specialist community, started seeing that was the way things were rolling, they came back around and reconsidered and got involved. But the net result was there was this idea that you don't really have to have great diagnostic records, because one, this third party's doing it, and two, they would also say things like, well, it's compromised treatment. It's not really comprehensive. We're just going to make things better. We're just going to make it look better. We're just going to make the teeth straighter in the front.
Anterior 6.
We're just going to make it straighter in the front. And so you don't have to worry about that. Or they would say stuff like, they're adults. They're not growing anymore. So why would you need cephalometrics? Mm-hmm. Because they're not growing. And they would use those kind of arguments, and because the big hurdle's cephalometrics, right? Mm-hmm. Wouldn't you say?
Yeah, absolutely.
I mean,
absolutely.
It's hard. It costs a lot of money, and there weren't, especially then, there weren't a lot of imaging centers, so there wasn't any place to send if you wanted to do it right and you wanted the basic records, you had to have cephalometrics. Yeah. So
the Ceph is the biggest basically deterrent to getting started.
Yeah.
I've been in multiple classes of yours, and I meet new people in your classes, and I just like to talk to them. And in speaking with them, they say, well, I don't have a Ceph. What do you think? I said, well, you need to get a Ceph. I'm doing this class and I want to get started, but I don't have a Ceph. I said, well, find somebody to take a Ceph for you, or make sure you invest in a Ceph. And I've had many dentists tell me that they won't take your class if, like, when I'm talking to them, I'm telling them that they need to have a Ceph. I've told them, you can send the patient over to my office, I'll take a Ceph for you, and I'll send it to you. But you have to have a Ceph. And you get so many of these companies out there that I work with, that I've done aligners with as well, and they'll just tell you, you don't need a Ceph. Just send us the pano, x-rays, photos, the scan, and we're gonna do everything for you. It's like, but you need a Ceph. You need to diagnose it. And they don't care to have the Ceph, and you need it.
Do you feel like the doctors who are offering these clear aligner treatments and stuff like that, are they aware of where the liability
Should be.
rests and things like that?
And they should be, well, especially like, so I know you're in Oklahoma, I'm in Texas. So in reviewing cases with the state board, okay, and I mean, it's like, I'm not just like going out there talking to people, telling them I do this, but in reviewing cases, these Texas dentists should know what is required as far as standard of care, because there's a Dental Practice Act and there's all the rules for the standard of care are there. And so, for example, I get cases over and over and over that are being reviewed by orthodontists and myself. And the number one reason dentists, general dentists, and orthodontists do not get a pass. I've seen plenty of orthodontists actually have fines levied on them because they did not take good records. They did not do a Ceph, or even if they did do a Ceph and they do like what Dr. Williams says, the ortho salute, where they just look up at the top and look at the Ceph. There's a Ceph, or there is not a Ceph, but there was no diagnosis, there was no analysis. How do you really get the skeletal occlusion of a patient?
So you can't.
You can't, right? And so you're supposed to diagnose skeletal, dental, all these things. And these dentists, their excuse every single time is, the aligner company did not ask me to provide them a Ceph, but you have to have it for your records. And so I see that all the time, and everywhere I go and I talk to dentists, I tell them, if I'm in an aligner course, I tell the dentists that are sitting in the class, and I try to tell the instructors too, like, hey, please talk to these dentists, especially if you're lecturing in Texas. And Dr. Williams is real good about that with the classes, because he's in class and anybody can sit through that class and can say, he did tell us to do a Ceph. He goes over numerous visits of doing Ceph tracings and the Ceph analysis over and over and over to teach you that this is required. And people will leave the class and not do it. And it's sad, because it's there, it's supposed to be done, and it's not done. And then you cannot avoid liability for that.
Think about it this way. Set aside board
Requirements.
that side of it. Why does the board think that it's important enough that they would sanction somebody with, like, probating their license or suspending their license, or
CE recommend, CE hours required.
and CE and that sort? Where did they get this? Well, would you think that it's malpractice or that it's bad practice if somebody came in and they had a big hole in their molar and you just jumped in and did a root canal without any X-ray
Or a filling.
diagnosis or anything? And would you be comfortable if you did that treatment without having documented that you wrote it as a treatment plan, and that you diagnosed it, you wrote it as a treatment plan, and then you shared the financial responsibilities to the patient on all that stuff? I mean, it doesn't make any sense that you would ever do treatment without a diagnosis and a treatment plan, and it would be in your chart. And of course, now if you throw in insurance, you're not going to get paid. I mean, if you don't have the records to support your diagnosis, you won't get paid. And so and it never made any sense to me, because the cephalometrics have been foundational part of the database for diagnosing orthodontics forever. Just shortly after we got the hang of shooting x-rays, they started playing around with that. So it's been part of it forever. And to not have it doesn't make any sense. But I mean, it's not any more important than having, you got to have the diagnosis and a treatment plan. None of us necessarily stick to our treatment plan. You may tell a patient that's going to be a root canal. And then you get in there and you're like, hey, that wasn't as deep. It was kind of superimposed over the nerve. It's not as deep as I thought. I think I'm going to be able to fill this. And so you deviated from the original plan, but you had a plan. And but from the board's point of view, if you don't have a diagnosis and a treatment plan, and you got the supporting database for all of that, then you're skating on thin ice. That's all there is to it. But we've got lots of people looking over our shoulders. You've got insurance audits, you got Medicaid audits, you got civil suit audits, you got the board can audit.
You have other dentists.
Yeah. What if you have to transfer a case and they end up in an orthodontist's office that resents the fact that a general dentist is doing orthodontics? He's going to look those records over too. And I don't want it to be fear-based, though. I mean, if that's what it takes to motivate you, so be it. But what I want you to understand, and what this article I've been focusing on tries to point out, is that there's things that you cannot know about the case unless you have cephalometrics, unless you have a pan, unless you've done
an analysis,
model
a tracing
analysis, and all of that workup. You just can't know, and then that puts you in a really difficult place, because if the case does go south, then and it becomes something. All of us have extracted a tooth or tried to extract a tooth, and at the beginning of your career especially, and it didn't go well, and so you're like, we've been doing this for 3 hours. I'm gonna package you up and ship you off to the oral surgeon. We've got our tail between our legs and we feel all bad. But the oral surgeon, never made me feel bad about it, threw me under the bus or anything. They just cleaned it up.
Yeah.
But it's not always that way with orthodontics, because orthodontists have had the corner on this market. It's their turf. It's been their turf for a long, long time. And if your patient transfers out and goes to an orthodontist, and the records aren't there, he's in a really good position to throw you under the bus. Well, he did this all wrong. And so to me, it's important for all those reasons. When my practice opened the doors to the Premier program that the AOS has, which is a hands-on, doctors enroll and treat patients, but they're hands-on patients and do orthodontics in my office, and they come in from out of state. We were not willing to start that program until we cleared that with the board. So I had the good fortune of working with the state board and working with the board investigator in Oklahoma. And in that process, because you can imagine there's a lot of liability there, a lot of questions that we had. How can we make it possible for a dentist out of state who doesn't have a state license in Oklahoma to come and practice? And we managed after about 3 years to get that put together. And so we were able to license those dentists to come into our practice and work on my patients, which was really, really cool. Yeah. But in that process, those dentists had to be vetted and temporarily licensed. So in the vetting, that's when we really started seeing what you were saying. And that is that, the boards do care about cephalometric analysis and a good database, because we had doctors that had applied to come to that program that could not get a temporary license in Oklahoma. You know why? Because they'd already done a little bit of orthodontic
mishaps.
Yeah, and they'd already been in trouble for not having, specifically, not having cephalometric analysis, not having a cephalometric analysis.
It's a real deal. And I tell dentists all the time, and they tell me, no, I don't need it. No, I'm not going to have it, or it's cost prohibitive for me. And when I first met you and I started taking your classes in Orlando, I was in your first session, and I don't have money coming out of my ears or anything.
Yeah.
I was at your first session. I went home and I said, I need a Ceph. I don't have a Ceph. And I went back and forth, and I just bit the bullet and bought a Pano Ceph. And I said, if I'm going to do this, I need to do it right. And I don't want to be, the main thing for me that I tell dentists all the time is you do not want to be that guy or that gal practicing below the standard of care. You don't want to do that. Just don't do it. And for me, it's just always, it just surprises me how many dentists will use that cost excuse that is just a detriment to, to my financial situation right now to purchase a Ceph. But you have to have it if you're going to do ortho.
Yep.
It's just like dentists that I teach with and teach, for implants, and they insist on placing implants using a Ceph or a Pano or a PA. And you tell them you have to have a CBCT. Like that is the actual standard of care. That's what you use as a diagnostic tool for that, to place your implant, and they don't do it. Yeah. And when those cases come before the board, same exact thing. Yeah. The AAOMR says if you do not have a CBCT, you're below the standard of care. And so those are just things that I try to get across to dentists. And whenever I'm in a course, I tell them, make sure you have your Ceph, make sure you have a CBCT, make sure you have this. Well, that costs too much money. Well, you're gonna lose your license. That's gonna cost a lot more, or you'll have your license suspended, or they'll make you take, 500 hours of CE, to make up for what you lack.
I'll tell you what, CBCT, if people think that because of aligners or fast braces or 6-month smiles or all the other different orthodontic CE paths that are out there in the market, if they think that things are slowly drifting away from cephalometrics and having all this data, they're wrong. I'm telling you, I think that we're probably within 5 years of having to have CBCT, full volume CBCT for ortho, that cephalometrics won't be enough in 2D, that they'll expect you to have looked at it in 3D. So it's insane to think that you're on good ground not to have it. But more than that, I've been doing this a long time. I started ortho in '83, and so I've been doing this for 42 years.
Yeah.
And I would not start a case without a Ceph analysis, because I want to know, it tells me too much. It gives me way too much good information about how the case is going to behave and how to treat. I would not feel like I was treatment planning it appropriately unless I knew what kind of case it is. And some of that you can only establish. But now with airway, with airway coming on the scene in a big way, which is a big part of orthodontics too, I don't know that you've really done airway justice unless you've looked at a CBCT.
And I've repeated your classes so many times, and every single time in beginning or intermediate, you say that. Do not start a case without a Ceph.
So to summarize a bit, if a aligner company or instructor or someone tells you you don't need a Ceph, it's not their license that's on the line, right? That's
your license get on their teeth.
Yeah.
Look at the standard of care. All you have to do is do a real simple search on Google for Dental Practice Act in your state, and look at it and read it, which you should have read it anyway. I mean, it's our profession, right? We're agreeing that we're going to follow these standards of care. And so it's all there. It really is all there, And I see some patients where they've been started on ortho treatment and they didn't have a pano or even x-rays or any records. And the patient was like in a full-blown, stage 3 or stage 4 of perio diagnosis, and they were started on braces. And then at the end, the patient's wondering why their teeth are all loose, and they've been moved out of whatever little bone was there. And so, and all this is standard, that you should be, standard of care that you should be looking at. And it shocks me to see these cases come in, because we should know better. We should do better.
Well, if they want to take a deep dive, they don't have to just read the standard of care for your state. You can always do a search for board actions, and look at, because that's all public record,
It
by the
is.
way, which is never any fun whenever you've got a board action on your CV. And so it's like, you can review it. And if you were to search for boards, actions against dentists for
Orthodontics.
yeah, you'd get a lot of hits and it's almost always cephalometrics. And you were talking about this came to me, a lot of times the biggest hurdle is not the money, it's the footprint, because it's a big machine. And a lot of guys don't have an office that'll accommodate a Ceph arm. But there are other ways. You just got to get creative, because you could go to a CBCT generated and not have a 2D arm. But there's ways to get the information you need in that footprint. So so they're not going to. And there's imaging centers. I mean, it's so much simpler than it was. That now I sound like the old guy back in my day, but it is. There are a lot of imaging centers. Now, some of them suck, and you can't just have them shoot this Ceph and do the analysis for you and then stick it in your chart. Okay, I'm done. You need to actually know what it's saying and be able to interpret the Ceph and do your own analysis. But there's lots of places you can send your patients. I don't know why doctors don't go around putting MRI, machines in their and CAT scan machines in their offices. They send you to an imaging center. Why is it that a dentist can't feel comfortable going, oh, I don't have a...
Before a 2-year, treatment, it's like,
Yeah,
maybe we could do
we
it.
should send you over and have a...
Yeah. I mean, it's there, it's available. It's just a matter
it's
of,
out there.
I think it's just like, well, I think I can get away with it, and I really don't need it. This seems like a straightforward case, and then you can't really determine what the growth angles are. You can't determine whether they're in the box or not, and then you start the case and it opens up and just completely unravels on you, and then they get upset. And that's how the cases come up with the state board is a patient is upset with how things are resulting, and you don't know how to defend yourself and explain yourself to show the patient, look, this is everything we looked at.
You can't.
So I think that
You can't defend yourself. If you don't have records, you know what? That was one of my mentors, Dr. Dave Jackson, used to say, I will take a day off and come and testify on your behalf if you were ever civilly sued or had an investigation. If you send me your records and you did things the way I've told you to do it, I would be in your corner. But if a patient sues you and you call me and you tell me you don't have the records I've told you need to have, I'm going to tell you, just get your checkbook out.
Yeah.
Because you don't have a leg to stand on. If you don't have any records, you're screwed.
That brings up another kind of interesting point, and it may be a tangent, but I'm just going to highlight it a little bit. And that is that you talked about if a case unravels, that's kind of where these types of things come up. In some instances, it sometimes feels like the doctor isn't always doing the treatment plan when it comes to some of these aligner situations where they just sort of are relying on what
Somebody else.
software or a company is telling them.
Yeah, a tech often somewhere in Costa Rica, somewhere, running sitting in front of a computer running an algorithm. And I'm not bashing aligner therapy, but I have problems with the dentist not being involved in planning the case, how the teeth are to be moved, where we're going to place attachments, what order in which the teeth should be moved. And it's, I feel like that they should be involved and ought to be the person, to review it. But so many of these guys and gals that get into aligners, they'll get sent their ClinCheck or whatever you want to call the pre-check before they have all the aligners done. And they don't even know what they're looking at. They really don't even get enough education to understand it. So, yeah, they look good. they run the movie, they play the little movie, and
video.
they look really
Oh,
good
yeah,
at
it
the
looks
end.
good.
That's what we're looking for.
Yeah.
And dive in. And I just think that dentists ought to be more involved in that. That's why I push so hard for a course, because obviously we've got the course that Dr. Standard teaches on an introduction to aligner therapy, and he gets into some of that. And then you've got Dr. Patini, who has been doing this course on doing it yourself, that's more my cup of tea. I really like the idea of planning. I get the software and I get to map out the movements,
The control.
and I like the idea of doing it in steps, and only mapping out maybe 10 or 15 trades at the most, and where the algorithm's still good, because so many of these aligner cases, the algorithm starts breaking down. So you'll hear guys talk about, well, we had to do like 4 refinement tray series to get this case to an acceptable end. It's because the algorithm, is just it's just a predictive model. And the further down the road you get, the more it deviates from the predictive model. And I always tell classes, it's like weather. Weather's probably the one thing we've seen the most of that kind of algorithm. You've got all this data, and it predicts, based on these circumstances, how the weather's going to develop. And they're really good at 24 hours. They can predict weather pretty well for 24 hours, 48 hours. But by the 10-day forecast, it's really not doing a very good job. Well, the aligners is the same thing. It's an algorithm, and you think they're going to move this way, and it predicts it's going to move this way, but you start leaving that predictive model. So I like to stop and rescan and change it as I go along, so that I'm using the more predicted part of the algorithm that's truer over and over. And I'm also cheap and lazy, and I don't want to make a bunch of aligners that I don't need, so I'll only do 10 or so and then remap and start from there. And that makes more sense to me. But the bottom line, I'm involved. And you have to know to be involved. And if you don't know, then what the heck are you doing it? You shouldn't be doing aligners if you don't know orthodontics. And that's the problem. There is a billion people doing aligners, and they don't know anything about orthodontics. That's not a good place to be. Yeah.
Wanted to highlight the one other thing you said, which is that having a Ceph isn't enough. You need to have the analysis and all of that as part of that.
Absolutely. You see some orthodontists will take a Ceph and they just look at it, but they didn't, and maybe they've got so much experience that they can kind of extrapolate that information just from looking at it, right? But if it's not traced, it's going to be, there's going to be a fine. It's not traced. It's not, the analysis hasn't been done. The numbers haven't been entered. There should be a worksheet, and we look for that worksheet. We look for the treatment plan. We look for the diagnosis. We look for that Ceph, and we look for it to be traced. And that's the standard of care. I mean, that's just there.
I'm more sympathetic to an orthodontist because he's a specialist. He understands tooth movement, and he can almost run a flying by the seat of his pants because he knows he has the skill to react to things that aren't predicted.
Yeah.
So he says, I'm going to treat it regardless. I'm going to take this case to the finish line regardless, because the buck stops with me. So I can see where a guy who's been doing it for years thinks that they don't need it. And he probably doesn't need it because he's got the skills to handle it no matter what happens. Yeah. But most general dentists that are doing orthodontics are not in that position, and even if they are that good, they shouldn't be doing it. They can't defend it.
Yeah.
They can't, and neither can the orthodontist, and that's the reason why they get in trouble.
Yeah, so they don't get forgiven. So whether you're an orthodontist or a general dentist, if you didn't follow that standard that's actually documented, you're going to be facing fines. Yeah. So I try to always tell dentists that I speak to, please follow your standard of care.
Yeah. That was interesting. thanks for being here. Thank you for joining.
Well, thanks for asking.
Thank you.
Podcast.
Thank you. Thanks for having me.
Absolutely.